And the second presentation will be on the family's role in early detection and monitoring in pediatrics neurosurgery specifically, a shared lesson between Uganda and the UK. Dr. Lara Hobbs will be presenting, and Dr. Lara is a member of the Acquired Brain Spine Injuries Group, and she's working as NIHR Research Fellow in the Department of Engineering at the University of Cambridge and consultant anesthetist at the East and North Hertfordshire NHS Teaching Trust. She has played a critical role in providing consultancy to the WHO in the East Mediterranean region, including advocacy on policy relating to trauma system and delivering mass casualty management training. Her research focuses on the role of families and communities in healthcare across different resource settings. And the floor is yours, Dr. Lar.
Thank you very much. That was a very kind introduction, Avanisa. So I think you've done the introduction brilliantly for me. So I'm Laura, and today I'm just going to talk about my experience of the work that we've done with the ABSI group, looking at kind of the global role of families in deterioration, and then how we've then translated that into some work that we're now going to try and do moving forward in the UK, learning those lessons. So a little bit of background, I'm sure that this has already been covered today about what research we do in the NIHR ABSI group. As Ebenezer mentioned, I work in the Department of Engineering, and so my research kind of cross-cuts a lot of the themes that we look at, including mapping care, understanding care, and thinking about capacity building and innovation. Engineering, what we think about is how we can redesign healthcare systems to make them better, but thinking more broadly about the whole system. And my research in particular thinks about the role of families and communities right from the point of illness or injury at home, all the way through to hospitalization and then discharge home. So during the last 3 years, I've looked at the role of families and communities globally, but also alongside my clinical work in the UK and some of the collaborators in the ABSI group, we've seen that a lot of the issues of health inequalities and challenges about health advocacy, particularly for families, are not limited to particular income settings. And actually that we can learn an awful lot from our colleagues around the world about how we might improve systems of healthcare to meaningfully utilise the amazing resource that is families and advocates. So this presentation is just going to be a little bit of a snapshot of what we've done and then where we're going to go forward from here. So the research I've been doing is part of a PhD in the Department of Engineering, and broadly speaking, I've looked in two sort of halves. So first, trying to understand globally what the role of families and communities are in acute care systems. So I've interviewed 22 people across 17 countries, across all income settings. Trying to understand from a healthcare worker's perspective, what are the current roles of family members or community members, faith leaders, non-healthcare professionals, both formally within the system, but also all the informal ways that we know that they're involved, but perhaps aren't characterised in a formal way. And you can see from this chart, I've spoken to healthcare professionals from a wide range of specialties, so surgery, anesthesiology, intensive care, emergency medicine, general practitioners, allied health professionals, including physiotherapists, and quite a few of you on this call today have probably been interviewed by me, so thank you very much if you're one of those people. And then what I've also tried to do alongside this is work with our colleagues in Uganda to have a deeper look into a case study country and just try and have a look in different settings, in different cities, to see what the role of families are, particularly in hospital and with a focus on people who have brain and spinal injuries. So we have a long-standing partnership with our colleagues in Uganda, which started off as more of a clinical and operational partnership and is now a research partnership. And we developed a programme of a series of workshops and interviews with healthcare workers across Uganda to better understand in a lot more detail how family members are part of the system, and also what are the barriers to them seeking healthcare and what are the things that help them to seek healthcare. And this was supplemented by a programme of community engagement in urban Kampala and also in rural Kasuru to better understand how families are part of the healthcare system. And looking broadly at who are the people, so we talk a lot about families, but who are the other members of the community that we know are providing elements of healthcare? So we know that people are lay responders, good Samaritans. We know that there's a whole community of people that help get patients to hospital, but they're not part of the formal system. And so just really trying to understand who those people are, how we might get access to talk to them to better design a system where we utilise that expertise that we know the community members have. My slides are just stuck. So what we did initially, so back in 2024, during a visit to Kampala, I worked alongside one of our colleagues at the Uganda UK Health Alliance, Henry, to start to meet some of the people in the community who were involved, particularly as primary responders to trauma. And often road traffic accidents. So we met with some boda drivers and went to visit the Safe Boda operational hub to try and understand better what the role of these people are informally. So we met with the Safe Boda drivers who are doing a lot of work trying to improve road safety. So through things like helmet use, high-vis jackets, better tracking of vehicles, increased driving standards. So a whole programme of education, but also awareness to try and improve road safety. But we also then learnt about some of the burden of being a boda driver in somewhere like Kampala, in terms of the responsibility of sometimes delivering patients to hospital who've been injured, and being responsible for getting patients to hospital, because there's not necessarily an easy way to call an ambulance, and sometimes it's the quickest way. And we understood quite a lot about how they feel, sometimes a fear of helping bystanders, because actually then there is potentially the worry that they might be accused of being involved in any accident. And also from the kind of injured person or their family's point of view, the logistics of calling for help when you've had an accident are not always straightforward. It's not always easy to know who to call, which number to phone, how to get help. And also the financial impacts. So the impacts both for the Good Samaritans who are bringing patients to hospital, but also for the families who are maybe travelling to the patient, and then on the impacts on the patient of being admitted to hospital. In Kasuru, our collaborator, Dr. Daphne, who's I think on the call today, went to explore more broadly families' experiences accessing healthcare, in particular hospital care in remote areas, including how families detect when someone's unwell. And those families particularly sort of said for the young people and the elderly, it's a lot easier to advocate for them. But also the role of heads of families in deciding both where to seek healthcare and who to seek it from and when to seek it. And that's interesting because that's also what we're seeing in the UK with our community engagement, is that for different reasons, there's an awful lot of decision-making going on by family members and community members before a patient even meets their doctor or a nurse. They're making all of these decisions about where the best place to go is, how much it might cost, how they get there, the time it will take. And what we really want to do is better understand how we can then help those people to make sure that they are able to advocate in the best way possible. Other things that came out were the challenge of transport to hospital. So particularly in the remote rural areas, there was a use of stretchers, motorbikes and cars, and a very limited access to ambulances. Which, although is different to the UK, I think one of the things is that is a challenge that our parents in the UK talk about when bringing children to hospital, is that decision of, do I wait for the ambulance? Do I put them in the car? And so it's interesting that they're different concerns, but actually at the root of them is still decision-making, and at a highly stressful time. And I think really that sort of theme that was running through was actually that, there is this big burden of decision-making particularly for parents of children who have chronic or acute neurosurgical conditions or trauma, and they're having to decide where to go to hospital, which hospital. And that doesn't just have impacts on that patient and their parents, but also impacts on the wider family, other children. If a child has to be transferred to a specialised centre far away, that has a whole impact on the rest of the family. So very briefly, this led to sort of conversations both within our global work, but also locally, about hydrocephalus and how actually these children need to access specialist neurosurgical care, but they are often living very far away from those centres. And that really is the same in the UK as it is elsewhere. Obviously, the geography and the access is very different, but our children are often living a long way from the specialist centre and often will seek help from a normal district general hospital without specialist neurosurgical activity before they'll come. Hydrocephalus is also a condition where, particularly in the UK, thinking forward to our UK work, we know who these children usually are. So they're under one team. In our region in the east of England, we have one centre that all the children are looked after. And so it gives us the ability to explore in real detail a bit more with those parents and caregivers about their experiences and how we might be able to think about designing better systems for them. So thinking about this, we were thinking how can we better understand how parents can advocate, how they understand what they understand by deterioration, and what they might be interested in us developing to try and design tools that help them advocate for children when they deteriorate. And as I've said before, the experiences of parents in the UK are very similar, albeit different. Travel distances are the thing that they worry about. Specialist services. Sometimes the parents are the experts in this condition and they're faced with hospital doctors who maybe don't understand hydrocephalus in the same way that they do, but also the impacts of continually travelling for healthcare far away. And what we want to do is think about ways that we can enable families and caregivers to be engaged with healthcare and empower them to escalate when they think something's wrong, and to be able to advocate for their children better. And this actually is something that is not dependent on your income setting. It's actually a very common theme that we've seen across both settings. So building on the work done during our ABSI funding, we've applied for extra funding to try and explore these areas in more detail. So through an Alvarado grant through Cambridge, Africa, two of our Ugandan collaborators travelled to Kasuro to do a bit more community engagement to understand how families and caregivers are accessing healthcare in remote areas. And then through a Cambridge Biomedical Research Centre funded grant through the NIHR, we had some money to explore this programme of work in the UK. So building on those lessons we've learned globally, working with the Cambridge Children's Hospital, which is going to be a new children's hospital in the east of England, to look at how these children are travelling around our region and how we can make that pathway better for them. We've also consulted with a national charity, Harry's Hydrocephalus Awareness Trust, to understand better the lived experience of families with hydrocephalus in the UK. And this weekend, we're going to be talking to young people from Hertfordshire, which is about an hour from Cambridge, to understand their perspectives on how we might develop tools to help them advocate better in hospital and to help them get to the right place at the right time. So I'm very aware that I had a 15-minute slot and I hopefully haven't spoken for too long. I really wanted to thank all of our collaborators, but particularly Daphne and Arthur in Uganda, who have been really crucial to this work, Tom and the rest of the International Health Systems Group, and Sara Venturini, who some of these slides you'll be familiar with. But mostly I wanted to thank our partners, Uganda UK Health Alliance and Cambridge Global Health Partnerships, for helping support this work. And I think there'll be questions at the end. Thank you.